Good afternoon, everyone. Thanks for joining us for the April 2019 CDA vendor webinar. My name is Ahmed Tahir, and we'll be presenting along with my colleagues, Dr. Dan Pollock, Sarah Jones, Christy McLendon, Sheila Abner, Wendy Wise, Laura Bloom, Heather Dubendris, and Amy Webb. We will be presenting primarily CDA-related information that apply to the upcoming April 2019 and January 2020 release. As a reminder, please mute your phones and do not put us on hold. If you need to take another call, please hang up or disconnect from the Skype call and dial back in when you are ready. Please hold all questions until the end of the presentation. We are recording this webinar and will turn off the recording after all presenters have finished. The webinar will be posted on NHSN CDA submission support portal. We do have a lot to present, so we'll go ahead and start with Dr. Dan Pollock.
Thank you, Ahmed, and welcome everyone to the call. Next slide, please. So I want to talk briefly about the upcoming APIC annual conference. This year's conference will be in Philadelphia, June 12th through 14th. We will have an NHSN updates meeting on Thursday the 13th, beginning at 5 o'clock in the Pennsylvania Convention Center. And this is an opportunity for you to hear from NHSN directly the changes that we are going to be introducing later this year and in the future. Next slide. Also at the APIC conference upcoming, as we've done in years past, we'll be meeting one-on-one with vendors. So each CDA vendor, all of you on the call and others who may not be, have an opportunity to schedule time with us on either Tuesday, Wednesday, Thursday if needed, June 11th through 13th. We've had a very good turnout in recent years with these one-on-one meetings. It's a chance for each of the companies and the representatives to let us know how things are working for them with respect to NHSN, any questions, concerns, criticisms. We even take praise. That's all good. And it's a real dynamic way for us on the NHSN side to really understand what's going on with your efforts and your challenges. So we value your participation, and we would very much like to meet with as many of you as possible. As indicated on the slide, if you want to schedule a meeting, please send an email to the email address on the slide. The next slide. And speaking of APIC, we do have quarterly calls with APIC leadership as well, and we understand from those calls that through the APIC front office, we're learning that infection practitioners are often requesting more assistance from their CDA vendors in validating the data at the initial install and then after software updates. So to the extent that part of your interaction with IPs is a touch base as to whether or not they are getting sufficient support from you in the area of data validation, this is simply a reminder that they are dependent on our vendors to do a good part of this validation work, and that at least in some quarters they're requesting more help than they have had heretofore. And with that, the next slide will enable me to introduce Sarah Jones, my colleague here in the Division of Healthcare Quality Promotion, who's going to talk about the antimicrobial resistance challenge. Sarah.
Thanks, Dan. I'm Sarah Jones. I lead partnerships for the Division of Healthcare Quality Promotion. Wanted to give you guys a quick overview about our AMR challenge. I know some of you are aware of this and some of you have joined, but the AMR challenge is a global initiative that we're working with partners to make actionable commitments in the 5 areas on the right side of the screen: and tracking and data, infection prevention and control, antibiotic use, environment and sanitation, vaccines, diagnostics, and therapeutics. And it's a way for companies to show us the work that they're doing related to antibiotic resistance and actions that they can take to make a difference in this space. Next slide. We're looking for commitments to be in the core focus areas that I went over, but to also be measurable, to have a set time frame, and to have an impact. And so we're looking for organizations to think about ways they can contribute to antibiotic resistance and actions that they might be able to take to further the field. So we hope that you'll join. If you have any questions, please just follow up with us after the call. And Amy, I'll turn it back over to you.
Thanks, Sarah. And next we'll have Christy McClendon talking about general NHSN updates.
The following slides are just a few NHSN updates. Next slide. NHSN will continue with one major release a year. It includes protocol changes and CDA version updates with the effective date of January 1st for each year. We will also continue to include non-major releases as needed. Possible causes may be due to a new component, minor change request, defect and bug fixes, and infrastructure maintenance and support. Next slide. 9.3 is scheduled to be deployed April 27th, and possibly a 9.3.1 release in July to address urgent issues. Release 9.4 is scheduled to be deployed December 7th. Fixes for defects will be effective immediately, and change requests will be effective January 1st, 2020. Next slide. Just a reminder that a list of defects for each release can be found on the NHSN website. You can use the link provided on this slide. Next slide. NHSN is moving to an iSupport help desk solution. You should continue to send your CDA-related emails to the NHSN CDA mailbox and protocol-related emails to the NHSN mailbox. Next slide. Next, I will review defects and change requests that will be included in this month's 9.3 deployment. Next slide. Defect 8594 is to shore up a business rule for dialysis events. For an access site to be yes for pus, redness, or increased swelling, the same access site must be listed in the risk factors section. In the example shown, notice in the risk factors box, fistula and graft are selected as yes. Therefore, only the same sites may be selected as yes for pus, redness, or increased swelling. If another site is selected, an error message will be displayed. Next slide. CR 1758 is a soft rollout for the R3D3 dialysis summary CDA. It includes the optional field report no events. Dialysis summary CDAs for 2019 may either be the R3D1 or the R3D3 CDA version. For 2020 dialysis summaries only, the R3D3 CDA version will be valid. Supplemental documents have been distributed that include the IG, commented XML, and the mapping and coding table. Next slide. Defect 8500 affects CDA and CSV procedure imports. The business rules were shored up so that either hours or minutes must be greater than 0. If minutes are entered, then they must be less than or equal to 59. Defect 8592 is related to the R3D2 VAE CDA import. The location of mechanical ventilation was not being validated. The fix includes a lookup to ensure that the location of mechanical ventilation is a mapped facility location. Next slide. Defect 8600 addresses the issue for when CDAs from more than one facility are included in the same zip file for direct CDA automation. The PDF report has duplicate rows for some CDA imported types. This issue has been resolved. Next slide. Defect 8696 was just identified and will be included in the July release. When a VAE CDA is sent via direct CDA automation, the XML included in the response zip file does not contain all information provided in the PDF report. The table information for a successful CDA import is missing in the XML response. Next slide. Next will be Heather to present 9.3 AUR.
Thank you. The change requests and defects I'm reviewing today all relate to the antimicrobial resistance, or AR option. There are no CRs or defects in 9.3 that affect the AU option. CR 2179 will be implemented with NHSN Release 9.3. The error message produced by the application when duplicate AR events were uploaded in the same zip file were not the same error messages produced by the application when duplicate events were uploaded in separate zip files. Previously, when a user imported duplicate AR option events in the same zip file, the error message would read, duplicate import records or violation of the 14-day rule. We updated this message to add greater clarity and to be consistent with messages produced when duplicate events were uploaded in separate files. The 14-day error message now reads, you have entered an invasive specimen source, CSF or blood, AR event within 14 days of specimen collection date for a previously entered invasive source NHSN AR event. This is an additional invasive specimen source isolate. The 1 per month rule error message now reads, an AR event for non-invasive specimen source, urine or lower respiratory, has already been entered for this month. Only one non-invasive specimen AR event per patient per organism is allowed per month. The corrected error messages are much more detailed and will likely reduce troubleshooting time. Now we will briefly review select defects that will be fixed in the NHSN Release 9.3. NHSN is currently accepting AR events with the location of specimen collection outside the rules of the protocol. For example, events with an outpatient clinic location or inpatient FAC-wide in as the location of specimen collection are being incorrectly accepted by the application. After 9.3 is released, these files will fail to import with the error message, location is out of the AR protocol. In January 2019, NHSN made updates to the AR option drug panels. Following these updates, the AUR module team identified defects within the NHSN system which currently prevent Citrobacter amylonicus and Pseudomonas aeruginosa AR events from urine specimens reported with anti-P panels 24 or 22 UR for 2019 specimen collection dates from successfully uploading. In both instances, import of the file fails when it should successfully pass. These defects will be resolved in 9.3. When uploading an AR event CDA where the patient ID exceeds the 15-character maximum, NHSN currently generates the error, duplicate import record or violation of the 14-day rule. Once NHSN 9.3 is live, the application will instead generate the corrected error message, patient ID cannot be greater than 15 characters. Lastly, I'll cover defect 8428. Within an AR option event, the MIC sign, value, and interpretation for the first drug in the CDA file is not saving correctly in the database unless the MIC is the last individual test listed. When the MIC is the first individual test listed in the first drug of the file, the MIC data are populated in the EAST test sign, value, and interpretation. When the MIC is the second individual test listed in the first drug of the file, the MIC data are populated in the zone, sign, value, and interpretation. The workaround is to have the MIC sign, value, and interpretation as the last individual test listed for the first drug in the CDA file. The defects that I've just reviewed have all been tested and verified and will be included in the April 27, 2019 NHSN 9.3 release. With that, I'll hand things over to Laura for the 9.4 update. Thank you.
Thank you, Heather. Hello, my name is Laura Blum, and I am one of the SMEs for the NHSN AUR module. Today, I will be telling you about defects and change request updates for the NHSN AUR module 9.4 release, which is planned for December 2019. Change request 2125 and 2235, which is described on the next slide, encompass the AU option drug updates for 2020. Plasmamycin, eravacycline, omadacycline, baloxavir, marboxyl, arikayce, and colistin will be added to the AU option. These drugs will be optional and can be reported for any year. Ceftatorin, ceftabutin, ceftazoxime, sulfazoxolol, telithromycin, and ticarcillin clavulanate will be removed. These drugs must be excluded from AU CDA files beginning with January 2020 data. The AU files from January 2020 forward will fail to upload if these drugs are included. Change request 2235 will change meropenem vaborbactam from optional to required for AU option data starting January 1st, 2020. Meropenem vaborbactam will still be optional for any year prior to 2020. With the changes from change requests 2125 and 2235, the range of drugs accepted by NHSN will be 85 to 91, depending on whether the files include the 6 new optional drugs. We'd like to get your input regarding our process for adding new drugs to the NHSN AU option. We've historically allowed 1 year of optional reporting for new drugs before making them required. The same will be true for the 6 new drugs we're adding in 9.4. However, we'd like to hear feedback from you as to whether that's necessary. Would it be okay to make new drugs required when they're initially added to the NHSN AU option rather than optional for 1 year? Feel free to type your response in the chat box or email the help desk. Change request 2316 encompasses ARO pathogen list updates for 2020. Enterobacter aerogenes was reclassified as Klebsiella aerogenes. Certain species of Candida, Citrobacter, Enterobacter, Enterococcus, Streptococcus, Klebsiella, Proteus, and Pseudomonas will be removed. These changes will be reflected in the IDM Anti-P tab. Change request 2142 allows facilities to report no AR option events for facility-wide inpatient, emergency department, pediatric emergency department, and 24-hour observation area locations. This will allow facilities that have no AR events to report for a given month to clear their missing data alerts within NHSN. Defect 8613 prevents Staphylococcus aureus files from being accepted by the AR option unless the penicillin binding protein PBP2A test is listed before the MEC-A gene PCR test in the file structure. These tests will be accepted in any order once the defect is fixed. For now, the PBP2A test can be placed prior to the MEC-A PCR test within the file for acceptance. Now I'm going to hand it over to Wendy Wise, who will tell you about the AU synthetic dataset validation. Thank you.
Hi, thank you, Laura. So I'm Wendy Wise. I'm also one of the SMEs for the AUR module. And today I'm going to provide some exciting information about antimicrobial use synthetic dataset validation. Next slide, please. So as many of you know, CDC began an antimicrobial use, or AU, synthetic dataset pilot project in 2017. We've had success with the pilot, and we're taking steps to tie AU SDS validation into the NHSN application. So going through the AU SDS validation process will enable a smoother onboarding process for submitting AU option data into NHSN for both the vendor and the NHSN team. We have a tentative goal of requiring this validation process for all AU CDA vendors beginning in 2021. To pass AU SDS validation simply means taking the AU synthetic data set, processing it through your vendor system to appropriately aggregate the data, and outputting it to an Excel file. So then you'd upload that file to a web service tool, which will validate your aggregated AU data against an answer key. Beginning in 2020, we plan to post passing AU SDS vendor software information, such as vendor name, software version, on a public NHSN webpage. This will allow current and future customers to be aware of your services and successes with respect to the NHSN AU option validation. Next slide, please. We have two updates for the application related to AU SDS validation requirements slated for the NHSN Release 9.4 in December of this year. As a side note, if you monitor the list of defects and changes to NHSN, these two are change request 1865 and change request 2288. A process to register vendors that have passed AU synthetic dataset validation is needed. Because the AU SDS validation web service resides outside the NHSN application, we need to register passing vendors within the NHSN application. The AUR module SMEs will complete the AU SDS registration process for the given vendor once the vendor has produced a valid AU SDS file and a vendor OID. At the conclusion of the registration process, the AUR module SMEs will provide the vendor with an AU SDS validation ID number to be used in the production AU CDA files. Further instructions will be provided at a later date. We also need the application to capture and save this vendor information that we're asking to be populated in the author fields of the AU summary CDA files. So on the next slide, I'll explain the AU SDS specific vendor information a little further. Next slide, please. Oops. So as mentioned on the previous slide, we're requesting that vendors begin including the vendor information in the author fields of the AU CDA files. This will not require changes to the implementation guide. The items displayed in this table are the same as what is currently required and optional per the IG. The assigned author route will be the vendor OID, which must be obtained by the vendor through FinTech. The extension is also required and will be the AU SDS validation ID provided to the vendor after successfully completing the AU SDS validation and registration process. We would also like to receive the vendor software name, the software version, and the vendor name within the AU summary CDA file as shown in the table. Next slide. So although we are planning to phase in the validation process starting in 2020 in anticipation of a tentative 2021 requirement, you actually can begin working with the AU synthetic data set now by setting up your internal processes and testing against the answer key within the validation web service. We recommend starting the process of obtaining your vendor OID now as well. Then starting in January 2020, vendors will be asked to provide a successful AU SDS validation file so that we can confirm success and complete the AU SDS registration process. Once confirmed, the vendor will receive an AU SDS validation ID, which they can start to incorporate into the production AU summary CDA files along with the vendor OID. As part of this process, we'll also post the successful vendor's information on our public webpage. So beginning in 2021, we plan to reject AU summary CDA files if they do not include both the registered vendor OID and AU SDS validation ID. So next steps. In the coming months, we'll provide vendors with additional formal instructions for the AU SDS file validation process. The guidance will contain the steps to follow beginning with sending a passing AU SDS validation file to the CDA mailbox. For those of you not currently participating, we have instructions for generating the AU SDS validation file and are happy to share the AU SDS validation packet with you. It contains the AU synthetic dataset, the database schema, and instructions. Please send an email to NHSN CDA at cdc.gov if you'd like the packet of information or if you have general questions regarding the AU SDS validation requirement tentatively planned for 2021. Great. Up next is Sheila. She's going to discuss CDA vocabulary.
Thanks, Wendy. So for Release 9.4, effective January 2020, a major cleanup of pathogen codes has been initiated. In this screenshot, red lines from the current 2019 IDM show grayed out and hidden columns that will be deleted. Several of the hidden columns are SNOMED codes from previous years. Going forward, we plan to limit SNOMED codes to 2 columns, the current year and the previous year. We received lots of feedback that strike-through marks are problematic. So for this release, they are not being used to indicate content that has been deleted or corrected. Instead, cells with updated content will be bold with a green highlight, the same as added rows of new terms. The most prominent change for 2020 is that 520 terms of about 3,500 total have been inactivated. So they now have an I in the term type column. Most of these were synonyms that had had an S in the term type column. SNOMED retains former names of microorganisms as synonyms for historic purposes. Many of these are obsolete terms that are not needed for reporting any healthcare-associated infections. Examples in this screenshot are 2 alternate names for Enterobacter aerogenes, which is now Klebsiella aerogenes. And a smaller subset were preferred terms, meaning that they had had a P in the term type column. These are considered whole SNOMED concepts, so any associated synonyms would also be inactivated. And an example of a whole SNOMED concept would be Leptospira interrogans serogroup in the last 2 lines, or last 2 rows, with a preferred term and 1 synonym. And in that new code column, if you see an asterisk and a number, that's generally an indicator that it's a synonym. Other examples of inactivating whole SNOMED concepts at the top 4 rows are multiple subspecies of Aeromonas salmonicida. In the unlikely event of identifying an isolate as Aeromonas salmonicida achromogenes, it would be reported as Aeromonas salmonicida. Several CDC group terms have been inactivated, and then other terms at a level lower than species. So in this screenshot, biogroup and serogroup are examples. This cleanup focused on high-frequency bacterial pathogens and some Candida terms for the 9.4 release. Remaining terms should be completed with the next release for 2021. So keeping up with name changes is challenging, but we're planning to take SNOMED content changes into consideration with each major release effective January of each year instead of every other year. In this screenshot, 3 SNOMED concepts are blocked off to show the more notable name changes that take effect with January 20. Clostridium difficile is now Clostridioides difficile, and you can see that 1 synonym was inactivated. Propionibacterium acnes is now Cutibacterium acnes, and 4 additional synonyms have been inactivated. You'll see in the CC column that this new genus, Cutibacterium, is on the common commensals list. Enterobacter aerogenes is now back to having Klebsiella aerogenes as the preferred name, and 2 synonyms were inactivated. This one got a lot of attention since it's a high-frequency pathogen. Notice top pathogen with the purple highlight in column H. That column was updated based on reported data from 2015 through 2017, although I think this only affects manual entry. So this slide shows the decision-making process that went into inactivating the two synonyms for Klebsiella or Enterobacter aerogenes. On the left, you can see a screenshot from SNOMED where Aerobacter aerogenes and Klebsiella mobilis are still considered acceptable synonyms. But they have been inactivated in the NHSN value set based on the DSMZ site, which is a more current taxonomic name resource for bacteria. In DSMZ on the right, you can see that Aerobacter aerogenes is not even listed as a synonym, and Klebsiella mobilis is listed as an illegitimate name. So SNOMED is always in catch-up mode with the latest taxonomic name changes, and NHSN is always behind the latest SNOMED release. When responding to user requests regarding organisms not on our master list, we'll be referring to resources such as this for guidance on how to report those organisms. This slide shows three SNOMED concepts where two synonyms or near synonyms were blended into a single term and therefore a single row in the spreadsheet. Part of the overall goal of the cleanup effort is to remove duplicate terms as much as possible. So in the first example, not all group A streptococci are Streptococcus pyogenes, but most are, and they're treated as synonyms in SNOMED and elsewhere. Therefore, they've been combined into one term for NHSN reporting purposes. Same for group B streptococci, and gamma or non-hemolytic streptococcus has the same meaning, so they've been reduced to one row. We've had some internal discussion and differing opinions about the display name of Klebsiella or Enterobacter aerogenes. For this update, we decided against making it a blended term, but we're interested in gathering input about this possible naming convention for selected pathogens in the future. So with this slide, we're transitioning to reviewing changes to the Excel file format for all value sets used by NHSN implementation guides and the HAI_VOC spreadsheet. Value sets have been maintained in a spreadsheet with more than 120 tabs and growing. For R3D3, a new release format was introduced. The new HAI_VOC release format is similar to the format used for consolidated CDA value sets that are downloaded from VSAC. In this new release format, the more than 120 tabs have been reduced to a total of 5 tabs. There's a README tab for introductory comments, a value set index tab, which is shown here, that has metadata for the 111 value sets, a value set code list tab that has almost 12,000 rows of concepts for those 111 value sets, and it includes code system metadata. There's a tab for all concepts associated with single value bindings, and then the 12 code systems used for NHSN value sets are listed in a separate tab. So R3D3 included both the old and new formats of the Excel spreadsheets. Due to the heavy maintenance burden, we plan to discontinue the old format, and that decision is supported by some preliminary positive feedback that we're moving in the right direction based on the 2 emails displayed from vendors. We still have lots of room for improvement, so emails such as these are very useful. We've had some internal discussion about removing inactive rows of inactive terms for the next update in 2021. And it seems like there might be support for that based on a statement from a vendor in the previous slide that we're interested in getting clean representation of the upcoming version's active data. So there were 167 pre-existing inactive terms indicated by all the gray rows in this screenshot. And with 2020, we're adding 520 inactive terms. So the question that we're interested in gathering feedback on is, should those 687 rows be deleted completely for the 2021 update? And additional requests for feedback pertain to how we go forward with managing content in the pathogens value set. The maintenance process is primarily manual at this point, so it's labor intensive and at risk for errors. We've had internal discussion about existing bug drug concepts such as those displayed here for Klebsiella pneumoniae and subspecies after a recent request from a user asking for guidance on how to report ESBL pneumo, which that subspecies drug bug concept does not yet exist in SNOMED. And again, we've had differing opinions on how we should manage this content. We're interested in finding out what would be the consequences to removing the existing drug bug concepts, and how big would the burden be to ask submitters to roll up to the parent bug concept. Another issue is whether to start adding concepts from the finding hierarchy in SNOMED to more closely match what labs are reporting in their lab information systems. We're leaning toward not adding finding concepts and continuing to restrict the value set to concepts from the organism hierarchy. If there are strong opinions on these issues, we would like to know. I plan to attend the APIC conference, and I'm looking forward to participating in gathering feedback on how we can make improvements to NHSN vocabulary. And next is Ahmed to talk about patient safety component, NHSN release 9.4.
All right, thanks, Sheila. So I will go over changes for the 9.4 release, and we'll start with patient safety. All right, so starting with CR 1752, 1753, 1754, and 1755, these CRs are for patient safety summaries. Report no events will now be included in the CDA. This update will change the CDA version from R2D2.1 to R3D3 for 2020 summaries. Supplemental documents listed below will be available on our website in the near future. Right. CR 1974 is updates for BSI. The question that you see here in the screenshot will now be required. Currently, these questions are optional. Additionally, the rule stated in the box will be removed. The rule, if you see above, it says if any options from below are marked yes, then central line risk factor field should be no. So this rule will no longer be applicable once these questions are required. And again, supplemental documents listed here will be included with this update. For CR 2036, this is for manual entry only. USI will now be separated from UTI and made its own major level event. CR 2182 is adding NICU 5 as a new location. And this location will also coincide with the new neonatal component coming into NHSN. CR 2192 is our annual pathogen codes update, as just mentioned by Sheila. Please be sure to use the correct pathogen list as listed here. The pathogen list is also versioned, just so you know which list of codes you should be using. We did add additional columns to this pathogen list. 2 columns for dialysis have been added. 1 column is for manual dialysis entries only, and we'll have soft alerts included in those entries, and we'll go over that in the next few slides. And we also have a new column for LOS MEN pathogens. Right. CR 2216, we made an update to the business rules for CLIP. Chlorhexidine rule number 3 will be applicable for patients less than 4 months old and not to patients greater than 4 months old and have chlora contraindicator set to yes. CR 2218 updates Chapter 17 business rules. Secondary BSI will now allow positive blood culture for previously unallowed scenarios. And business rules number 2 for VCUF specific event will now include other signs and symptoms. Right. CR 2307 is updating rules for MDRO summaries dated for 2018 and onward. We did notice for FACWide in location for HOSP LTAC, HOSP PED LTAC, and HOSP Rehab had mismatching values. The CR will run a script to save the data correctly, but CDA vendors should correct this data as soon as possible so between now and the 9.4 deployment, the data being imported goes into the correct fields. Currently, we need to replace the MDRO patient days and MDRO admissions with the total patient days and admissions. And if you have CDI data that exists, you need to replace the CDI patient days and CDI admissions with the total facility patient days and admissions. And we also need to replace MDRO patient days and MDRO admissions with the total facility patient days and admissions. All right. The next we'll go into changes coming into dialysis for 9.4. So starting with CR 2193, we made updates to business rules for dialysis events. Positive blood culture should be yes if new antimicrobial start was a blood sample collected if this question is set to yes. CR 2194, as mentioned previously in the annual pathogen codes update, this is for manual entry only, and users will receive a soft alert or warning when selecting a virus, parasite, or prion as the identified pathogen for positive blood culture. CR 2225 is for manual entry only at this time. In the dialysis event form for the 3 event types that are collected, IV antimicrobial starts, positive blood cultures, or pus, redness, and swelling, each field will have the option to enter its own date. Currently, they all share only one field to enter the date. And for 2020, this will be available for manual entry only, and CDA will catch up in 2021. CR 2290 is to expand the author field in the CDA. We will now capture CDA vendor information in this field, and it will be saved in the database. For now, this field will be made optional. All right. In this slide here, we cover the compatibility changes occurring in 9.4 for patient safety and for dialysis. So you can see here that BSI will be updated from the R3D2 IG to R3D3. Patient safety summaries will be updated from R2D2.1 IG to R3D3 IG for 2020. And for dialysis summary, as mentioned before, there was a soft roll-on for R3D3 IG from the R3D1. So in 2019, both versions will be accepted for dialysis summary, but from 2020 and onwards, only R3D3 will be accepted for dialysis summary. Okay, next component is the biovigilance. So we only have one update here. We have CR 2278. This is the annual update to the ISBT values for biovigilance, and this list will be posted on our website under the toolkits. All right, next I'll cover some miscellaneous updates in NHSN. So outpatient is available in NHSN. It does include an event and denominator for same-day outcome measures, a new surgical site infection event, and a new denominator for procedure. If you would like an AMSearch test facility in the outpatient procedure component, complete the request found at the link shown on the screen and send to the CDA mailbox. This slide here displays the percentage of CDA imports versus manual entry or CSV import for procedures. The year date range was selected to include completed quarterly CMS reporting. Besides AU and AR, which are 100% CDA import, Notice the lab ID and dialysis events are the highest at 61 and 73% respectively. MDRO summary remains the lowest. The percentage for most events are slowly increasing, as you can see here on this slide. Just a quick update for direct CDA automation. We are holding at 14 vendors sending via direct. The number of facilities sending via direct is slowly increasing and is now greater than 6,000. For those of you who don't use direct yet, it is a batch submission process with no immediate reply. Turnaround time is based on volume of messages in the queue. If you are new to direct or want to learn more about direct, there is a direct toolkit on our NHSN website. Before you start your process, we do recommend that you schedule a call with us. We'll be happy to discuss direct process and recommend best practices. We will have a developer and direct administrator join the call for a technical discussion. Great. CDA support is available on NHSN website. The first link is to the main CDA submission portal. Other important links provided on this slide are to the CDA toolkit and guide to CDA versions. And just as a reminder, NHSN supports CDA versions that are valid for the past 2 years. A few more helpful resources may be found using the following links. The first one is the NHSN newsletter. Second link is for release notes and communication updates. And the last is the defect list and release schedule. The pre-production test site, also called NPPT, is a copy of the NHSN development environment. It includes analysis and reporting functionality, so AU and AR data may be verified. It does not include CDA automation or groups. There are also no SAMS credentials required. If you would like to have a test facility in the pre-production environment, complete the form found on the website and email to our mailbox, NHSN CDA at cdc.gov. The pre-prod test site is currently in the 9.3 environment. As a reminder, at the login, read the important message. Version 9.4 code is scheduled to be deployed to NPPT around October. Beta test period is also currently scheduled for October 7th through October 18th. And as you know, during this period, any new locations and monthly plans are not saved, but any information added prior to or after the beta test periods will be saved. And as always, your feedback is very important to us and assists us in improving changes and correcting issues. So we thank you all for all the feedback you give to us. Right? Taking a look at some future CDAs coming in, as mentioned before, we do have a new neonatal component planned to be added to NHSN in the summer of 2020. It will include patient-level event denominator for late onset sepsis and meningitis, and it will be CDA import only. For 2021, the AR summary will include report no events. Dialysis event will have the addition of the date fields being included via CDA, and the NICU summary for patient safety will have report no events for PED VAE and also include EMV days. For 2021, for outpatient procedure component, events and denominators are scheduled to be available via CDA. All right. And a new functionality being worked on in NHSN for CDA vendors. So vendors will have the ability to request the map location data for a facility. The vendors will first be required to go through a registration process, and all information will be handled via direct. The facilities do have the ability to opt out of this service, and we'll provide more information in the near future as we come along. All right, and as always, we welcome feedback from the vendors and all of our users. We do offer individual vendor conference calls. Make sure you are on the NHSN CDA email distribution list. To be added, email the NHSN CDA mailbox with your request. And also, please be sure to visit our CSSP website. All right, and this concludes our April 2019 CDA presentation. We will now turn off the recording. Thank you.